For some more folks to join us. Good morning, everyone. I'm Beljeet and I'm the CWDA and CFPIC ALAIM consultant. And I will turn it over to, I think I see Diana, so I'll switch to Renita with CWDA.
Good morning, everyone. My name is Renita Polk. I am the Deputy Director of Aging, Disability, and Older Adult Services with CWDA. Good to see everyone.
Andrea.
Good morning, everybody. I'm Andrea Sobrato with CFPIC. It's great to see y'all.
And then I believe I saw Diana can't come in.
Yes, Diana Boyer, Director of Policy for Child Welfare and Older Adults here at CWDA, County Welfare Directors Association.
Great, thank you. And I'm just gonna switch it back to Andrea. She's gonna walk us through a couple of things before we get started.
Great. Sure. Yeah, it's great to see everybody. We've got Kaiser and our adult programs in California. So we are hoping that this will feel like a really interactive kind of meet and greet. We'll start with Kaiser talking a little bit about their organization, who's who, and a lot of the mechanics and the organizational sort of behind the scenes so that we can make sure that everybody kind of understands like how to reach out to Kaiser and what they offer their members. And just the frequently asked questions that I think counties are asking now that we have an MOU surfacing. So I will also just share my screen really quick. I'm going to drop this link into the chat right after we get going. But this is the CFPIC's website that hosts some of the resources. If you look at the link, it'll take you right here, and you'll see on this page the Managed Care IHSS Kitchen Sink MOU template from May, and then the updated one from August, and then the corresponding webinar and the presentation slides that we walked through in May. You've got that right there. And then I'm going to go back to the overall CFPIC page for capacity building and system integration. And then I'm going to show right here the health plan meetings over here on the right. If you click on this right here, Adults IHSS, it will take you right to, you see we've got Anthem, the recording from the Anthem meet and greet and the PowerPoint there, and then HealthNet. And so Kaiser's will be right there as soon as this meeting concludes. And so if you have colleagues that weren't here, feel free to just jump on this link and you will be all caught up. And I'm going to turn it over to Kaiser in just a moment, but I do want to say a couple of things, and that is, please drop questions as Kaiser begins to present. If you have questions, drop them into chat. We will facilitate throwing the questions. We'll sort of mine the chat and make sure that we can get the questions routed in real time. And if not, there's a 30-minute Q&A time at the end. We'll drop the PowerPoint into the chat. We just want this to feel really accessible. And as a CFPIC, we're partnering with CWDA and are really excited to bring you guys this meet and greet this morning. And Beljeet, I don't know if you want to say anything else or we turn it right over to Kaiser.
No, we're going to hand it over to Kaiser.
Hello, everyone. So happy to be with you all. My name is Vanessa Davis, and I'm joined here by several of my colleagues. Thank you so much, Andrew. We are really excited to be here to really just meet you all and share a little bit about Kaiser Permanente's Medi-Cal program and some of the changes that went into effect earlier this year with the direct contract. And as Andrea said, some frequently asked questions and hopefully some specific information regarding our MOU team and process and how we can better partner with you all with regards to some of the in-home social services collaboration efforts. So with that, I will introduce, we've got an introduction today. We'll do an overview. And then, as I said, we'll kind of do a little bit of a double click on some of the MOU pieces and highlight some of the IHSS services. We will definitely leave ample time for Q&A as well. So my name is Vanessa Davis. I'm a director with our Medi-Cal program. I oversee our external engagements and other strategic initiatives, including our incentive payment programs. And I'm joined here today by several of my KP colleagues, and they will introduce themselves. I'll pass it over to Lana.
muted there, Lana. If it's the Zoom, we're a Teams family here, but it's
Thank you
okay.
so much. I appreciate that. Okay, it looks like I'm not on mute anymore, but hello everybody. I'm Mana and I'm the senior manager on our MOU implementation team here at Kaiser. We also have a couple of folks from our team here on the call. We have Emily Arienza and Melissa Gonzalez, just to name a few of us here. And our team is serving as the leads for operationalization of the MOUs after the MOUs have been executed. And we'll talk a little bit more about our team in just a little bit. So I'm gonna pass it over to Love.
Good morning, everyone. My name is Love Melnichuk, and I'm the contract manager for IHSS and child welfare with KP team and with our Medi-Cal contract management team. I've came here from to KP from DHCS. I worked there for a little bit, and prior to that, I actually worked for a local county here as an IHSS social worker for 7 years. So I'm very excited to be here and to present for you guys. And I'll pass it on to Phil Perez.
Good morning, everyone. My name is Phil Perez. I'm the MOU liaison for KP, covering several different domains. So IHSS, regional centers, long-term services and supports, and targeted case management. I cover Northern California. Ingrid, I'll pass it over to her. She covers Southern California.
Hi, good afternoon. Good morning. I wanted to be afternoon already. My name is Ingrid Smith, and I am the MOU liaison for IHSS and LTSS, the same as Phil. Between Phil and I, we both come with a lot of experience with IHSS, regional centers, and other community-based support. So I'm happy to be here.
All right, and you'll see a few others from the KP team on and available to answer questions during the QA portion of the meeting. So I just want to start by grounding us in Kaiser Permanente's mission. And our mission is really to provide high quality, affordable healthcare services and to improve the health of our members and the communities we serve. And this has been our mission for over 75 years. We have had a dedication to not just the high quality, affordable services for our members, but really a focus on communities. And our commitment within our Medi-Cal program is really an extension and an expression of that broader commitment to serving our communities. And with the changes that we'll talk about in a moment that went into effect earlier this year with regards to the expansion of our Medi-Cal program across the state, 32 counties, this is really a doubling down on that commitment and the ways that we can deepen our partnerships and collaboration with all of you and many other stakeholders. So next slide, please. All right, so as I've referenced, earlier this year, effective January 1st, Kaiser Permanente went into a direct contract with the California Department of Healthcare Services, or DHCS, to provide coverage and care for Medi-Cal enrollees in 32 California counties. We'll take a look at a map in a moment, but essentially what this direct contract enabled is the expansion of KP's Medi-Cal services from 22 to 32 counties. It allows KP to offer our Medi-Cal coverage in all areas of the state where we had previously, and to this day, offer commercial healthcare coverage. And then it's extended access to Kaiser Permanente care, including specialty care, to non-members through various community partners in select areas and pilot programs such as the Population Health Management Initiative. We're really proud of our Medi-Cal program and the high quality and equitable care that we're able to provide for our Medi-Cal enrollees. Next slide, please. So this is a look at the map of Kaiser Permanente's Medi-Cal coverage footprint. You'll see the dark blue, the Northern California counties, which represent over 400,000 Medi-Cal members, and the counties listed below. And then in Southern California, over 600,000 members. This is totaling, as of July, just over 1.1 million KP Medi-Cal members. Next slide, please. All right, so this is really an opportunity to just do a little bit of a focus on who is eligible for Medi-Cal enrollment into Kaiser Permanente. So there's several different buckets or populations who are eligible to join KP Medi-Cal effective January of this year. So the first and largest bucket is those who have had KP coverage within the past 12 months. Typically, this is inclusive of folks who've had coverage through a different insurance product. So through their employer-sponsored coverage or through the marketplace, for example. The second bucket is those who are qualified through family linkages of existing Kaiser Permanente members. You'll see on the right-hand side what some of those qualified family linkages include. The third bucket is those who are foster youth and former foster youth, and that's up to age 26. And then the final bucket is those who are duals, both covered by Medicare and Medi-Cal. So in some counties, and this is largely dependent on capacity, a KP provider capacity, KP will be now participating in auto assignment, or what's typically called default enrollment, for those beneficiaries who do not select a particular health plan. So this is new for us and went into effect in certain counties in 2024. Next slide, please. All right, so we wanted to spend a little bit of time talking about enhanced care management, community supports, and our approach to offering some of these benefits and services. So I wanted to just orient us, and many of us have probably seen this and are familiar, but I like to kind of remind us of kind of where these benefits and services fit into, which is really through the Cal-AIM initiative or Medi-Cal transformation. So Medi-Cal transformation is a multi-year initiative by the California Department of Healthcare Services, really aimed at transforming the Medi-Cal program in California to improve health outcomes and address health disparities among Medi-Cal beneficiaries. There are three primary goals of Cal-AIM. The first is around identifying and managing member risk and need through whole person care approaches and really addressing the social determinants of health. The second is really focusing on moving Medi-Cal to a more streamlined and consistent system through reducing complexity and increasing flexibility. And the third is about improving quality outcomes and driving delivery system transformation through value-based initiatives, modernization of systems, and payment reform. So the Medi-Cal transformation consists of multiple different initiatives, including enhanced care management and community supports, but also including other efforts like the incentive payment program or the justice involved strategy. So there are 11 different initiatives that Cal-AIM encompasses. We're going to talk about a couple of them now. Next slide, please. All right, so I wanted to kind of ground us in, before we get into enhanced care management community supports, a big focus of Cal-AIM is identifying and managing member risk and need through whole person care approaches. So through what's called population health management, Medi-Cal members are screened and assessed for risk and are stratified into different risk tiers. So looking at what's on the left-hand side of the slide here, based on the level of risk assessment, the member is assigned to a care management program that is best suited to their needs and to their kind of risk level. So this ranges from basic population health management, which is focusing on care coordination and comprehensive wellness and prevention programs, to complex case management, which is really for the higher and medium rising risk folks and provides ongoing chronic care coordination and then disease-specific management interventions. And then at the top of the of the care management pyramid, if you will, is the enhanced care management. So enhanced care management is a Medi-Cal benefit, which takes a whole person interdisciplinary approach to care for members with the most complex medical and social needs. So enhanced care management, just as distinct from the other care management programs, really has a focus on both clinical and non-clinical needs through the systematic coordination of services and comprehensive care management that is community-based. So you'll note the services in purple indicate it's a service that is offered through a community-based entity outside of Kaiser. It is interdisciplinary. Enhanced care management is high touch and person-centered. So we'll happy to answer any more questions with regards to ECM, but just shifting gears to community supports, and we'll spend some time, I know, taking an IHSS lens to some of the community support services later on in the presentation. But at broad brushstrokes, community supports are non-medical services offered to Medi-Cal members to address health-related social needs, really focusing on improving health and then also potentially avoiding more costly healthcare expenses. So these are sometimes referred to as in lieu of services because they're in lieu of more costly healthcare utilization. So the services are provided again here by community-based providers that specialize in providing the specific service. There are 14 total community supports, and I believe we'll take a look at those a bit later in the presentation. Next slide, please. So one of the things that we're really excited about is this ECM outreach campaign pilot. So to really ensure that we're raising community awareness of ECM and driving enhanced care management referrals and meeting members where they're at, which is in the community, Kaiser Permanente is planning a communications outreach campaign in partnership with a nonprofit public health communications firm called the Public Good Projects to do a trusted messenger social media influencer campaign. And I will admit that 2 years ago, if you asked me what a micro influencer was, I did not know. But I've had the opportunity now to work with PGP on a few different outreach campaigns focusing on education around housing legal rights or COVID-19 vaccine equity. We did some work with them on Medi-Cal redeterminations. So we've had a lot of successful partnerships with PGP leveraging this trusted messenger influencer campaign. So the purpose of the campaign is really to evaluate an active and creative way to increase overall community awareness of these programs and ultimately to drive referral to ensure that we're able to get members the services and the supports that they need. So the messages are really targeting two populations, first focusing on our foster youth population of focus, and then our birth equity population of focus, as well as the community providers that serve these populations. The birth equity population will be a statewide influencer campaign, whereas our focus on foster youth is going to be starting in Sacramento and San Bernardino counties in a more targeted approach. We are aiming to implement the pilot in Q4 and happy to answer any questions about it in the chat or later on during our Q&A. Next slide. All right, so I referenced earlier, what are the community supports? As I mentioned, there are 14 different total community supports currently, and each of them have specific eligibility criteria for DHCS. These include supports for housing insecurity, like housing navigation, housing deposits, supports to keep people safely at home, including those at risk for institutionalization, supports to improve a chronic condition, such as asthma remediation services and medically tailored meals, and then support to recover from acute intoxication. Next slide, please. So Kaiser Permanente is partnering with 3 network lead entities to really ensure the development of a strong community partner network to offer these services, enhanced care management, community supports, and the community health worker benefit, which we did not get into today, but is another benefit that KP is offering through our Medi-Cal program. The network lead entity essentially serves as a kind of hub and spoke model, where the network leads are centralizing some of the coordination of services and contracting to the community-based providers. It's important to note, however, that Kaiser Permanente retains all of the oversight of eligibility, member notifications, quality, and grievances. Another function and element of the network lead entity model is that it really enables us to have a robust network across the 32 counties. It was really important to Kaiser Permanente and to DHCS that when we went live earlier this year in the 32 counties, that we had comprehensive coverage for all of these services to the extent that that was possible, and to serving the unique populations of focus. And then all of this is really fueled and enabled by the close collaboration with community-based partners. So the network lead entities provide the enhanced care management, community support, and community health worker services through and in close collaboration with community-based organizations with both geographic as well as population of focus expertise. So a little bit more on the network lead entity. We can advance to the slides. Here are our 3 network lead entities. We went through a very rigorous and extensive RFI, RFP process in 2023 to identify the 3 entities here. Full Circle Health Network is our children, youth, and families network lead entity. They have expertise in working with these populations. The second network lead entity is Independent Living Systems, or ILS. This is not only a longstanding enhanced care management and community supports provider, but they also have extensive expertise as a network entity. And then Partners in Care Foundation, focusing primarily in Southern California. Next slide. So for those providers or agencies that are interested in serving KP Medi-Cal members for the enhanced care management, community supports, or community health worker services, the way that they would initiate that process is to email the appropriate network lead, specifying the services that the agency or organization provides, the geography that's serviced, as well as the population expertise. Next slide. And for folks who want to be able to submit a referral for enhanced care management or community supports, we are taking a no wrong door approach to referrals. This is really important to us. We want to reduce the barriers to members being able to receive these services to the extent that we're able to. So referrals are accepted from any source: members, providers, community-based organizations, families, county agencies, and may be placed through email or phone. We have a referral form, and we'll make sure you all have the link that is included here. But just note that we will also accept a referral form from any other managed care plan as well. So if you are familiar and have access to a different health plan's referral form for ACM or CS, we're happy to take that as well. Next slide, please. All right, and we just wanted to make sure that you have some links to helpful links and contacts. So I won't walk through that here, but we want to make sure that you have the information that you need at your fingertips. My team, our external engagement inbox, is listed at the bottom here below. And myself and Andrew and many of our other colleagues that are joined today are also happy to answer any questions and share our contact information as well. So I think with that, I will turn it over to our MOU team, and I think Lana is going to take the next set of slides. Thank you all.
Thank you, Vanessa. Okay, so we can start with Journey to Today. If we can maybe skip 2 slides, I believe. Let's skip this slide. Let's go to the third slide. Thank you. Okay, so beginning January 1st of this year, Kaiser has assumed all managed care organization functions for all counties where KP has a commercial footprint. This expands KP's medical footprint to 32 counties, 5 from KP's existing direct contract counties, 17 from KP's existing planned partner counties, and 10 brand new to KP counties for a total of 32 counties with a single direct contract with DHCS. By aligning to the commercial footprint, KP is able to better serve the needs of our members who may need a transition between plan types, ensuring that there is continuity of care for our members. Excellent. Q1 of this year, the MOU work group was formed consisting of the MOU contract management team, the MOU implementation team, program liaisons, and subject matter experts, which will be providing just a little bit more information within the upcoming slides. So let's move forward to the next slide. Today, the MOU work group continues to evolve as we streamline our processes, make adjustments to meet changing requirements, and also meet requirements of county and agency preferences, and make progress towards execution and operationalization. We continue to outreach to county agencies and onboard new team members to support work streams and bodies of work as we prepare for steady state operations. Next slide, please. Okay, so there are a total of 9 MOU types to be executed and operationalized this year, across 32 counties, I should say. When negotiating these MOUs through our redlining process, we take a very collaborative approach and we seek mutually beneficial agreements. We place emphasis on alignment with DHCS contracts, or DCHS requirements, I should say, while also ensuring that our post-signature implementations are in alignment with best practices, missions, and goals, allowing for standardization, efficiencies, and effortless experiences with our counties and agencies. Love, I'll pass it over to you.
Thank you. We'll talk regarding MOU execution and implementation in the next slide. So as an MOU contract manager, we manage in contract negotiations, red lines, approvals, and signature execution. We report to DHCS on quarterly updates. We also post-execution, we manage contract storage, posting for DHCS reporting, and ongoing maintenance. And I'll pass it back to you, Lana, for the rest of the roles.
Thanks, Love. So our MOU coordinators are the designated MCP responsible party, and they're noted as the contractual MCP liaisons within all of our MOUs. They are the primary point of contact for county partners, and post-execution are responsible for facilitating quarterly meetings and managing relationships with counties and internal KP partners. Our MOU coordinators also lead the implementation and operationalization efforts post-MOU execution. They serve as subject matter generalists and collaborate with program liaisons and clinical experts in ensuring that our workflows and our policies and procedures are implemented in accordance with our MOU requirements and in accordance with our higher standards of care coordination and care delivery. Our program liaisons, our program liaison partners, I should say, partner with our care delivery operations teams and our medical group clinical experts on program care coordination workflows. They serve and are responsible as the primary point of contact for their respective programs and domains, and also lead efforts for triaging issues from county and county agencies pertaining to patient level care coordination and navigation. And lastly, our medical group clinical teams are our clinical subject matter experts. They coordinate and collaborate with our MOU coordinators and program liaisons by providing their expertise and strategic thought partnerships to inform the development of our care coordination workflows, our operational processes, and also support the triaging of issues for resolution. Next slide, please. And I think I'm going to pass it over to you, Lev.
Thank you. So our execution, MOU execution, before MOU is signed, as a contract manager, we will collaborate with our external partners through the MOU scope to define collaboration purpose and scope with all parties to begin collaboration. We also have our MOU kickoff meeting. It's to facilitate kickoff discussion with all parties to begin MOU redline discussions through our MOU red lines, which is to draft, revise, and finalize MOU terms with all parties towards execution, address requirements, changes, and establish amendment process. And finally, the contract managers are specialized by MOU type, for example, IHSS, child welfare, LHD, WIC, and so on and so forth. And I'll pass it back to you, Anna.
Love. Okay, so after the MOUs are executed, our MOU coordinators remain the point of contact for the counties. They are also assigned about 2 to 3 counties at the moment for management. And then post MOU execution, our MOU coordinators are also responsible for providing training materials to county agencies within 60 days to meet our MOU requirements for training and development. They also facilitate quarterly meetings to meet our quarterly meeting requirements as outlined in the MOUs. And lastly, they also collaborate with our program liaisons and our clinical experts, as mentioned earlier, in the development implementation of our workflows and PMPs across the MOU types, to ensuring that we're meeting MOU requirements and our best practices. I believe that's it. Thank you all. Oh, I'm sorry. One more slide. Sorry, I'm going to pass it over to you, Love.
Okay, no worries. So most of you have seen this already as we did the kickoff meetings with most of the counties here, but I'll go over this for the counties that haven't seen this yet. So phase 1 is the redlining of the MOU. As a contract manager, we schedule our kickoff meeting. Then the contract manager maintains execution tracker, leads the MOU redlining, manages county MOU correspondences, obtains SME and liaison feedback, and sends to legal for material changes. This step also includes the county's input as well, and them sending to their SMEs and their legal teams. Finally, all parties agree when the MOU is ready for signature. Phase 2 is when we identify the MOUs that are ready for signature and we prepare necessary documents to submit those. Contract manager submits the pre-signature memo to signatory, and contract manager facilitates the briefing meeting and sends approved MOUs for signature via Adobe Sign. And then phase 3 is the implementation of the MOU. Contract manager stores executed MOUs and related legal correspondences for future references and plans for annual updates. Contract manager teams files executed MOUs for DHCS and post to kp.org. And finally, contract manager hands off the MOU to the MOU coordinator, who schedules quarterly meetings and maintains the ongoing relationship in steady state. Next slide. And we'll pass it on to our SMEs, Ingrid and Phil.
Thanks, Love. Appreciate it. Just want to start, I think, again, thank you all for being here. We appreciate just all the collaboration that is going on across the state. There's a lot of work going on. We're entering kind of new territory, right, with CalAIM, where healthcare and social services are overlapping more than they have in the past. And it's calling for a new level of collaboration. It's calling for a higher level of care coordination. A lot of work going on. So who are the liaisons, right? Well, let me back up. I'm Phil Perez, IHSS liaison right here at KP. And Ingrid is my counterpart. Again, she covers Southern California. And we're going to kind of go over some of these, the work that we're doing through that IHSS lens, right? So the liaison, we like to think of our role as somebody who brings all the different pieces together. We work with community, with regional centers in the community. We work with you all, county IHSS departments, TCM, to coordinate care. We work to support referrals, to manage escalations. And it's our job to know what's going on at the county level. It's our job to be familiar with the trends that are going on, the issues maybe that you all bring up, and then bring that back to the team, so internally KP, so that as we work to develop our systems internally, that they work together, that we're in alignment. We also do work with providers. So direct care providers, we work with SNFs, with intermediate care facilities. We support a lot of work that they do around claims and authorizations and contracting, and then also being aware of what's going on when folks are transitioning out of those settings into the community and maybe need IHSS. So we're intimately involved in that process as well. KP care coordination, we work internally with our own teams as they develop internal processes and systems and workflows. We work with the healthcare coordinators on our side. We work with the Permanente medical group with our doctors, our physicians on that side to make sure that everything is in alignment as we are familiar again with these community partners and referring back to the direct service providers as well to make sure again everything is working seamlessly and as well as possible. Our KP members, obviously, why we exist, right? To support our KP members. We work with them as well. We are member facing. While we don't necessarily work with every single referral or every single question that member services, we refer to member services as well. But if there's an escalation with one of our KP members, say something isn't going well, or there's someone that's stuck, right? This is new. We're ironing out the wrinkles across the state, and there are going to be situations likely where something we need to find a solution for something. We're there to reach out and sort of play air traffic control and say, hey, we haven't found a solution for this. We want to be able to solve for this, and we can help members kind of navigate through that process to make sure that they get the supports that they need. Specifically to KP, myself and Ingrid, we both cover multiple domains. Again, so we cover IHSS, TCM, regional centers, and LTSS. And that uniquely positions us being familiar with all these different domains to address and help our internal teams develop systems and processes to support some of those more complex healthcare needs across the different domains. Next slide. So our KP members, from the other previous slide from the liaison's perspective, right, of what we do, but the KP member is really at the core of all that we do, right, and their core support team, right. So in this situation, we have an IHSS recipient, and who is their support team? They can have a variety of different entities involved in their lives. They have family members who support them. They could have a regional center where they have a service coordinator and a whole host of services on that side. They work with an IHSS worker receiving, their IHSS hours. They could be involved with other community organizations and receive supports in those avenues. They have their physicians, their healthcare, their doctors, their specialists who are making referrals as well. And then they have the KP liaison, us, and also other internal healthcare coordinators and social workers who are going to support this KP member. And as you can imagine, this could be quite complex, right? So to refer back to some of the work that, or refer back to the ECM, which Vanessa was speaking about earlier, we bring in that ECM lead care manager to sort of have an overarching approach to make sure that all these different services are working well together, right? So that ECM is a Medi-Cal benefit. It's a whole person interdisciplinary approach that addresses both, again, those medical and the social needs of the member. And again, it's a high-touch, person-centered, systematic approach to care coordination. So that lead care manager is going to coordinate across different platforms, different agencies, work with the families, and to ensure that that things are not missed and that appropriate follow-up is completed as necessary. They're going to help coordinate, for example, with IHSS and community supports and regional centers, as there are some services that overlap there. What does that look like? Who does what? Are the referrals being followed up on? Are there any gaps in the services that we're not aware of? And then which direction do we go to try and fill that gap? Do we go to family? Do we go to regional center? Do we go to KP? So trying to make sure that everything is addressed in this individual's life just to support all of their needs. Next slide. I'll hand it over to Ingrid.
Good morning. And that's where community supports come in. As we shared before a little bit earlier in some slides, KP is participating in this program through CalAIM. And although there's many different domains, one in particular that follows along with IHSS is the personal care and homemaking service. For the full service support of an individual, we take a look at all areas if the individual has Medi-Cal and qualifies for support. And we're going to show you a little difference of how the two, so that we can prevent a duplication of services. Next slide.
All right, so IHSS and community supports, right? Where do they overlap? How do they interact together? So side by side here, we have IHSS on the left and the KP community supports, specifically that personal care and homemaker on the right. So from the top down, service description, really these services are really, really similar. I can't ever say exact, right? But for all intents and purposes, they're essentially like the same service. And in our assessment process, we look at, a lot of the same things that you all look at when you're doing your evaluations. But the care provider, next step down, care provider, that is different, right? So on the IHSS side, it can be a family member, it could be a friend, they could go through the network, the provider network. They get to choose who those workers are going to be. On our side, community supports, the care provider is provided through KP's, the NLEs, the network lead entities. Number of hours and limitations of services. So IHSS side is a max number of 283 a month, right? Ongoing with annual reassessments. On the KP side for community supports, we look at number of hours. The initial number of hours are provided based on assessed need again, but the max is 320 hours for 60 days, right? And that is so to allow for the referral and the evaluation on the IHSS side. And then services will transition to IHSS once IHSS hours are approved, right? So it's time limited for the community supports. And again, funding agency, obviously you all folks fund that IHSS, and then the KP Medi-Cal on our side. Questions about this slide? I know this was something that I think some people were interested in.
We do have a question in the chat box.
All right, can somebody read it here? I'm trying to pull my
I'll read it for you, Phil. It says, does Kaiser have a criteria and the process identified for members they will be referring to IHSS for an assessment for service? And can this be shared with the group?
Great question. Yeah, we do have a criteria, and I'll have to touch base with our lead on our implementation lead on that to see what we can send out to you.
In regards to this, yeah,
in regards to look at how we're identifying those specific members. But we are, I know we do have a process. I can't speak to it exactly right now, but I know we do have a process to identify those members to refer out.
And the next question is 320 hours a year or of a lifetime? That's just for the assessment process. If a member requires over and beyond, it's something that we take a look at, and it's all based on assessed need. So it's very similar to an individual who may qualify for a regional center. And as you know, a regional center individual, we look at what they call a generic resource. Where does that need follow in? And KP under community supports, because CalAIM will ask, what is the extra over and beyond? It's something that KP will look at based on the medical support that's needed. And again, for both services, as we shared before, individual who qualifies for IHSS should have Medi-Cal. If you don't have Medi-Cal, that leads to others. As you guys know, being IHSS providers or understanding the IHSS system, that could lead to a share of costs. So what we want to do is we want to ensure that all of our members have Medi-Cal. Okay. There's a couple other, I think I answered the other questions.
How many of our IHSS recipients have many of them have difficult finding providers? Do the NLEs have a strong pool of providers? Yes, they do. I think they do have. They're building it. They're continuing to build their provider pool, right? I think there's a shortage of workers across the country. Right. So I think that's just a reality that we're all dealing with, but we're working to build that up. And I think we do have a lot of confidence in our NLEs. They're great organizations who do a great job. So and I haven't heard of any issues with that yet, but probably more to come on that. I hope that they continue to build out their network.
So there's another question here on the non-duplication of services. Does that mean that they cannot have KP community supports while they actively have IHSS? The answer to that is just like anything else, is looking at where that need may be. So if they maximize their IHSS eligibility and there still is a need that for this member in their home, KP may look at to see what that need is. However, as you can see from the community supports, it may not be an ADL or protective supervision. It may be another need such as transportation or in-home or meals, not necessarily prepped meals in their home, but meals that can be delivered that can come under another community supports. So it doesn't necessarily have to be personal care and homemaking, which is what we're showing you here in this service. It may be another community support. So that's not technically a duplication. It's all based on what that one of the 14 or one of the 17 different categories that we have. And then the last part of this question is, what if we assess differently and IHSS does not provide a service that KP does? Well, that's just like any other community support. We're not just looking at this under community. We're also going to look at other community organizations that are out there that can provide. And that's the role of the ECM lead staff, where that lead person is going to look at that person, look at the entire environment and say, hey, what else is needed to help this member stay safely in their home? And that's where those particular pieces come in, Diane. I hope I was able to answer that for you. And then I see a hand up from Shannon.
Good morning. Thank you, Ingrid. Thank you, Philip, for providing this presentation. I'm from San Francisco County, IHSS. Often we have clients that are referred to us by hospital staff, discharge planners, or even, I imagine, some MCPs who will be gearing up to make more referrals. Part of the requirement is not only having a disability that's lasting a year or longer and having an assessed need, but having a health certification. We call it the State of California Form 873. That can sometimes be a challenge for our clients or your members getting that form completed, working with their doctor. Is there any type of collaborative work that can be done under this ECM complex care model that you can help us get this form completed, which not only helps on your end, but the member just overall?
Absolutely. It's always a conversation with the physician and the healthcare coordinators. Is that correct, Phil? The healthcare coordinators, ECM?
It could be the healthcare coordinators if there's no ECM, but in the case that there's ECM, right, I think that's exactly what it's for, is you have somebody who has more complex care needs, right? And they may have some limitations, or they may be struggling to fill out those forms, or they, for whatever reason, they struggle to complete that. I think individuals like that would be appropriate, could potentially be appropriate for ECM, and their lead care manager could help them complete that. We'll actually do in the next couple slides here. We'll give an example where we're going to do two simultaneous referrals, one to community supports to satisfy that need immediately, and then also to IHSS to go through the assessment process. So we try and fill that gap right away, knowing that later on, when you guys do your assessment, you're going to come in with those IHSS hours. And then to speak to that question earlier about sometimes it takes longer than 60 days, we can extend that for another 60 days if the assessment process is not complete.
Right. And that was, Shannon, that was perfect because it leads to our next slide. So we're just going to give you a typical KP member. Here's a KP profile of a member. Here's a 78-year-old single male who has a diagnosis of epilepsy and type 1 diabetes. He's insulin dependent and hypertension. Over time, any other 78-year-old, the health is declining, and he's having some issues around handling those daily care needs as he lives alone. He can no longer clean his home. He needs help showering, and he frequently misses his appointments because of the things that are stated here, not able to cook, maybe not able to manage some of the things around his life. So how would this healthcare coordinator, this is a KP member who is being supported, the healthcare coordinator would then, after the physician's appointment, take a look at what those needs may be. Next slide shows, next slide. Here's that member, and this is, as Phil had just shared with you, how we would look at this concurrently, because applying for IHSS and applying for community support services, a lot of time, or any other community support, you would do it simultaneously because we want to make sure that the healthcare need of the individual is there. Who is that person that can help them? So the ECM or lead staff there, or even the healthcare coordinator, would direct that person to how to apply for IHSS. As we all know, there's no organization, no MCP can specifically apply for IHSS for the person, but we'll make sure that they are walked through that process. As anything, as a liaison, if there's some questions about the actual IHSS process, we're here at KP, Phil and I, to be able to answer those questions. Maybe that form you couldn't get there, or the family may have some questions around it. The healthcare coordinator may have some questions around it. We can guide and direct and ensure that we get that information there. So when they're referred, we look at all avenues. One of the things that we pride ourselves on is really understanding IHSS, and as we know that there are other entities that utilize and guide families, one being the I always call it the client's rights advocate, but it's Disabilities Rights California, where they have a lot of resources to help these individuals know what that assessment process looks like. So we can make sure that the member is addressing those questions. How do you live alone? If you didn't have help, what would you do? These are the questions that are being asked of the member. It's not about, oh, Johnny has someone across the street, he comes over to help. We want to be able to say, if Johnny lives alone, if he doesn't have any help, how is he going to be able to cook, clean, bathe, answer the door, dial 911, etc.? So this is kind of the path that we take. Right as we're going through the IHSS process, the member is receiving up to, that's where those 60 days up to 320 hours come in. We're going to make sure that there's some support that's in place. As any other organization that's out there in our community, nationwide, care providing services are are limited. Not as many people want to be that care provider, but they're doing their best to try to find it. And so our network entities, before being assigned to a member, they're going to make sure that there's staff available to help the member through it. Once the IHSS assessment is done, as we have to by law, we transition the personal care assistance over to IHSS. But the biggest thing is, under this community support, this KP member will continue to be engaged by the KP support system to ensure that his needs are well taken care of. Okay. Do we have any questions around that process? I think this, Shannon, was really your question, so we kind of answered that. Phil, I see a couple questions in the chat. I don't know if we're able to answer those.
Let's see. Lack of MC or wrong aid code delay the IHSS intake process. Would those prevent the community supports eligibility?
Diane, that sounds like it is a IHSS issue, or are you saying that it's on the physician form that the diagnosis is incorrect? Because the Medi-Cal is beyond KP or any other MCP. That's something that we would, or even IHSS would work with Medi-Cal directly to ensure that they have the right aid code for that. But yes, they would work closely with the ECM if you recognize that, hey, this is a problem. They're listed under Medi-Cal fee-for-service opposed to straight Medi-Cal, which may, prevent it. But again, as Shannon stated before, we have to make sure that there's a disability that's longer than a year. The need is there. And so they may have emergency Medi-Cal. They may not have the right Medi-Cal, but I will just ask that when we look at the Medi-Cal aid code, it's typically on the IHSS side first to make that eligibility or that determination, get the information so that we can move. So for example, let me answer that question. If someone has emergency Medi-Cal and it's not a long-term disability that they would have, instead of going through the IHSS process for it, that automatically gives this member a need to say, hey, we may have to go through the personal care homemaking support service instead of IHSS, because this isn't a long ongoing need that this member may have. So their need is still taken care of, but it's taken care of under the community support side. So yes, Medi-Cal in itself can delay a part of the assessment for IHSS, but it does not stop the service.
They would need to have Medi-Cal though to receive the KP.
Yes. Absolutely.
Community supports though. Another building on next question here in the comments, building on Shannon's question, IHSS requires that the recipient manage all employee responsibilities, interviewing, training, scheduling, and authorizing timesheets. Unfortunately, a large number of our recipients aren't able to manage these responsibilities. Would this type of recipient be appropriate for an ECM referral?
Well, wouldn't
I
be
think
good, Phil.
I think well, I think it would. They would absolutely be responsible. I mean, they would be appropriate for an ECM referral. I think there's a lot of risks associated there that would qualify them for ECM. Now, I think that lead care manager can help support, with these types of things. But I think more importantly, they're probably going to help find resources and help them coordinate supports to be able to meet these needs, right? Because they're not going to be that lead care manager. The ECM is time limited. It's not going to be forever, right? So they're going to try to set up a system, provide supports, and put those in place so there's ongoing supports moving forward.
And there's also an organization called Personal Assistance Service Council. I know there's one in Southern California. I can, Phil can get you the information for NorCal, but it is designed for IHSS recipients to help them in all these needs as well. So the Personal Assistance Service Council is designed. It also has a repository of IHSS workers. So if individuals are looking for staff to help them, PASC is there to help them identify staffing, which is what we had on our other slide about an agency that could assist them. They're designed, and that role of a PASC member or worker will also help with the interviewing, the training, et cetera. So they do have that support as well. And one of the other great things about PASC is that they also do different types of workshops so that their support team and everyone else can also partner to gather more information around that. Okay, so I hope I answered that question there. I think there's another one, Phil.
Yeah, they keep coming in here. Let's see. We got, it's cycling through faster than I can. What if the individual temporarily drops off Medi-Cal? That's not the one I was reading. Sorry. It's like moving while I am trying to read it.
Here it is. It's Diana's question. Diana, you have your hand up. Are you going to answer that? Is this the question you wanted to ask?
Actually, I wanted to ask a different question.
Okay. Okay, why don't you go ahead and ask that, and we'll try to answer that one, and then we'll answer your different questions as well.
Sorry. It was just, I'm like, okay, I'm tired of typing. I'll talk. On the Personal Care Services Council, and it'll be great to get the contact for the Northern California. In IHSS, as you know, it's this consumer-driven program, and so the consumers select their providers. So would the council work with the preferred provider of the client? Like, these are personal care services, so they want like a relative or someone that's kind of known and close to them to be providing it. So just curious, like if they would work with the provider of choice for the consumer.
Yes, because it's person-centered. And these are questions that they would ask them through that interview process. Also, with their repository of employees, there's various resources that they have to help the member in interviewing and even setting up a training program. So the website is, once I stop talking, I can't multitask, but once I stop talking, I could drop the link in here. But it's very resourceful in being able to provide all of those. And they also do talks to various organizations. So you can bring them into your organization to talk with you to be able to assist the individual around the care of their personal care needs in their home.
Okay. And then I guess maybe just as something for all of us to be thinking about, but I assume the council, though, will pay a certain amount through their organization. But as you know, in counties, we have different bargaining agreements. And so there's different pay rates for providers. And so that could change once they come into the IHSS program. So, just something to be thinking about, but appreciate that link.
Okay, and then Bambi just stated that the PASC is LA County, but each county has their own public authority registry. So you may want to take a look at it, but I'll send that one. And then people can just look to see if it's one specific to their county.
Another question here. During this transition period where KP is providing the personal homemaker service, is this through a private organization? Yes, it's through our NLE. So the NLE, the network lead entity, is going to be the one who provides that personal care homemaker service. What if, the next question, what if the individual temporarily drops off Medi-Cal due to non-renewal? If they are currently receiving ECM, how quickly would ECM end? Would the member receive a notice before ECM or CS ends? You know, that is a great question. I actually don't have an answer to that, but I'm noting that here, and we'll have to get back to you on that.
Right. We'll ask our network lead entity staff for that one. And then there was one last question here that says, are all KP managers touch points with members telephonically, or do they see them in person at their home? Are you meaning the NLEs, Shannon, or are you meaning the actual healthcare coordinator that's at the hospital or clinic?
And I may have been misunderstanding. I was thinking at KP, I kind of thinking like a care coordination. So a member will be matched with someone on the KP side who's kind of following their care, looking at the utilization of services.
Okay,
So that person, yeah.
So the healthcare coordinators or KP are internal telephonically, or if they come for a medical appointment, there could be, but most of them are telephonic. Okay. The NLE, which is the lead care person, that's the one who will assign someone, and they could be face to face. They have the ability to be face to face with the member on that one.
Thank you.
Mm-hmm.
All right. Reading through these here.
Vanessa, you might, for Colby's question here with the no wrong door approach, can IHSS social worker refer an IHSS recipient directly to community support provider in lieu of completing the KP referral form? If so, would the IHSS recipient need to complete an authorization to release information, or is this covered through the IHSS KP MOU? Vanessa, if you have an answer, because I know that you do the ECM training around that?
I want to take it back to the team. My understanding is that KP does still need to complete the authorization for the community support service. But we can take it back and confirm and follow up with the group.
Thank you. And this one too, Kimberly, just to let you know that if the member is needing service right away, which is kind of what the personal care homemaking service does under the community support, that individual would have most likely met with their physician. So the healthcare coordinator would be there with them. For an individual just to go to apply for IHSS, it's typically who asks them to do it, right? What does that need for them to apply for IHSS? So yes, it can work concurrently if it came from IHSS over to community supports. But on the other side of it is who is the one that's directing that process for the individual to apply for the service. So we want to be mindful of that. Like, you know, who brought you here? Like a regional center is always a question like, who brought you this? Who was the one who referred you to the organization? And then we try to collaborate together so that we can guide the member, especially with IHSS since it's so person-centered.
On that question, though, Kimberly, are you asking if we're going to continue to provide community or the homemaker services while they look for an IHSS worker? Is that what the question is?
Like, hi, this is, let me take, good morning. Well, you said like the 320 hours, and I'm thinking, so if somebody is getting assessed for IHSS services, and they still need to find a provider, that can take time. at, I mean, only speaking for myself, if you don't have a family member or a friend already lined up and you have to go through the public authority or your provider, that can take time to find that right fit. So my question is, would those hours that were authorized through Kaiser, would those kind of continue until a provider is found for this person?
I think that's a great question. And you know, full transparency, these are some things that I think that we're still trying to work out, right?
Sure.
So some of the guidance that's been provided through DHCS, it's high level.
Yeah.
And so some of these more nuanced questions, this is exactly why I think this is works exciting, because we get to work with you all on these nuanced pieces, right? Like these are things that are missed at the high level, but when you start working, how are we going to operationalize this, right? These are the types of questions that I think are great and we have to work out. And so, you know, I'm going to take this question and kind of get a more solid answer, take it back to the team and get a more solid answer for you. I don't want to misspeak on it.
Okay, thank you so much.
And Diana, you have one more question. Or you have
Well,
a
no,
question,
actually
another
more
question.
of a comment, which
Okay.
thank you, Phil, because that's completely valid and we agree. And I think we are having the similar conversation on the child welfare side and ECM and referrals with your other provider, which is Full Circle Health Network, which is more focused on the kids. And, you know, I might think about having this kind of operational like guidance or process like thought through or talked through with your provider, with the counties and yourselves and the provider too, because we're just wanting to, you know, build sort of just very smooth transitions. And especially for, you know, any maybe related or any maybe provider that we might be building into the county network. So just wanting to keep that door open for maybe a deeper dive and maybe even including the network provider in this conversation.
Thank you,
Thanks.
Diana.
Yeah, thank you. I appreciate that. You know, yeah, and that's, I know we touch on some of these things when we're in these MOU discussions as well. You know, we talk through the PMPs or what are those really going to look like. So there's just a lot more work to come, I think. And we at the same time, you know, exactly what you're saying. We want to make sure that this is a smooth transition from one to the other. That's the intent, right? To make sure that we're supporting folks, you know, in that gap and make sure that they have what they need. So absolutely, we're on board with that. So appreciate that.
Any more questions?
Any other questions?
All right, next slide, Phil.
All right. Is Katie on? Is she going to hop on this one, or are we?
I am on, but Phil, you're welcome to take it.
Okay. Well, this is just big picture, kind of looking ahead, you know, as part of the direct contract, you know, KP is executing these MOUs, right? We've talked about with 32 counties across the state. We've made a lot of progress. We've 28 out of 32 counties we've engaged with IHSS MOU discussions. We're working through the language on that. And we found that we've actually been able to come to a lot of, we're finding agreed upon language that works for both parties. And really that's the intent, right? I know sometimes initially right off the bat, this is all new. Like, you know, sometimes there's like, hey, what's going on here? What are you requesting of us? What are we signing? What are the direction guidance that you're getting now from DHS? You guys, you know, report to DSS, right? The different state departments. So, but what we found is we've been able to find some great agreed upon language on that. IHSS liaisons, our team, we're in place. We're here to answer questions again and try and bring all the different pieces together to make sure that it works. And then just overall as KP, we're here to answer questions, provide support. If there's anything that you guys need, please don't hesitate to reach out. Ingrid and I are always available. You can reach out to us. We have our information here on the next slide. I know the rest of the KP team too. If for some reason all you can find is Andrew's email, I'm sure he'd be happy to direct you to the right person, right? So please reach out to any of us if you guys have any questions or support needs. And here we have just some fast facts, IHSS facts and context here, really to confirm KP enrollment. We have some checks here, confirm some locations here, confirm MCP selection. If the IHSS liaison assistance is needed, you can send an email there. That's an inbox that both Ingrid and I monitor. So if for some reason I'm out, you're not just emailing me, nobody's responding to you. So email that liaison inbox, and one of us will get to you. It's always helpful to include these CIN, name, date of birth. I'm sure there's a million John Smiths, right? So sometimes we'll get an email, hey, can you help us with this person? And we need a little more info than that. And then just some contacts here on the right that are important. Ingrid and I are here at the bottom. NCAL that's my phone number at the top at the NCAL, and then Ingrid's number is the SCAL number, and then there's that email again. So please, we just want to overemphasize, reach out to us if you have questions, concerns, or anything that just is worth noting you want to make us aware of. Please don't hesitate to reach out. I think that's it for our side.
Great, thank you. I'm going to ask that we bring down the slide so that we can all be on one, and we go. We have at least about 15 minutes left until the end of this presentation and meet and greet. And so just open it up for questions. Again, if there was a question that you posted in the chat and it didn't get answered, this is an opportunity. So just use the raise hand feature and I'll get to you. I don't think I see any hands raised. Oh, Shannon.
I wasn't fast enough to find the virtual raised hand. I'm not Kimberly, but I don't know if we answered her question because I'm curious for the answer. And I may skip past if it was already answered. It's just about us approving a client. It's taking some time. And KP's network lead, can they stay on and work with the member/client until IHSS provider has been found? Going back to consumer driven, many times it takes a while for a recipient to be successfully matched. So they can go through many rounds of interviewing providers, not feeling comfortable, letting them go. So will KP's rep or lead stay the course and kind of be there to close the loop? If we kind of go back, kind of thinking back to the closed loop referral, I don't know if that falls under that.
Well, so I think there's two things. We chatted on it, but we kind of, I think, took it a little different direction. So, because when we talked about it, it was, is KP going to continue to provide community supports, that the homemaker service, personal care homemaker, while they look for an IHSS worker? That is a wonderful question that I think I don't want to misspeak on. So I think we're going to take that back to the team and figure out where that line is drawn, so to speak. But in relation to the NLE, like if they have ECM, that lead care manager is still going to stick with them. So they will still stay, right? And they can continue to support. They can even maybe help network and find, other help find an IHSS worker, right? Maybe they have some connections or whatnot. So they can support in that process. But those are two different things. That makes sense. So one's the ECM that will stay on, and then the other is the community supports, which I think I want to get a more solid answer for you. I have some ideas and thoughts on it, but I don't want to misspeak on it. So I think we'll take it back to the team and get back to you on that one.
Thank you. And then I see Elsie from San Joaquin.
Hi there. Can you hear me?
Yes.
Okay. My other concern is that when you don't have a family member, and if you have extensive personal care, those are the really hard ones to find a provider for, because people are okay with doing some light personal care and domestic, but when you get to the extensive, adult diaper briefs and it's extremely difficult to finding those. So I don't know if Kaiser is and I'm posing this question to the other two for our county, is if there could be some kind of a stipend when there is no relationship to the provider and the person is extensive hands-on care. So I want to just pose it out there.
Yeah, I don't know that that's something that we offer right now. I definitely understand the challenge there, right? And having kind of been in this world for a long time, it's something that just it's an ongoing need, right? And I feel like, in particular, in the past several years, that um, is a shortage of direct service providers across the board. So, but that's definitely something we can take back to the team and talk through.
Yeah, and I'll
Right.
just jump in. Oh, sorry, go ahead.
No, I was just going to jump in and kind of give an answer for that. Is that there's a lot of nursing agencies that are, CNAs or LVNs that may be able to, because maybe they're looking for additional work, which is the great thing about this repository, that the registry, rather, I kept calling it a repository, but it's a registry that the PASC has. Or even as a county, you could, if you don't have access to PASC, you can look at nursing agencies through other social organizations that need that. A lot of the nursing agencies have stepped up to take on that particular support. So the care manager or family member may look at that for a kind of support, but again, we may be looking at something else. And yes, Vanessa, this is definitely a question that you might be able to answer.
It's more actually kind of this kind of discussion is exactly the kind of collaboration that we want to cultivate through these forums. And certainly I know Phil and Ingrid and others will be in more regular communication with the specific IHSS county programs. But part of what's happening is this is a kind of a massive transformation and a new way of working for us within Medi-Cal managed care. And so the more we can identify where are the pain points or where are the sort of roadblocks or gaps, whether it's, hyper specific populations or certain needs or length of service, et cetera, I think in these forums and through that feedback and collaboration, our voice collectively is really powerful. And we want to just keep lines of communication open so we can really, again, continue to be committed to kind of keeping the member at the center and realize the current sort of ambition of the DHCS vision for these kinds of collaborations, but also know that we're learning as we go as well. So just wanted to give some voice to that.
Diana?
Yes, I appreciate that. And I'd say that we'd welcome a partnership, Vanessa, in that space, because we're finding that the guidance has been largely driven only by DHCS with very little coordination and discussion with DSS, which is our oversight department. And we're finding some inconsistencies, and we're, bringing that back to DSS. We've also brought it back to DHSS to say, could you clarify this or that? So as we dive deeper, it would help if we just, I think if we're both saying the same thing, like we need guidance or clarification here, please do so.
Absolutely. Yeah.
And one thing I was going to ask too, like in looking at the community supports guide, which is another thing, like the department keeps updating things. They just issued a draft update that we're looking at right now on some things, not in personal care though. When I looked at the personal care in the community supports guide, I didn't see paramedical services listed, which is what we do cover in IHSS. So that maybe is another area for us to talk about in terms of gaps exploration.
Yeah, I love that. I don't know if Phil, did you want to respond to that specific piece on paramedical?
No, actually, I'm just noting it here. I want to go dig deep and look and see see what it says there. But I'm noting it here. I'm shaking my head yes because I'm like, great point. Exactly why these, like you said, Vanessa, why these meetings are great and important because these are things we need to look into and again, another wrinkle to iron out. So I'm noting it here.
And the moment might not be this moment quite now, but what I'll do and take as an action step from this conversation, and we'll sync up internally with our KP colleagues on the call, but also want to give it a heads up to our Medi-Cal policy and advocacy leaders, just that, especially in conversations through the California Association of Health Plans and other advocacy channels that we have, not that there's a specific relitigation at this moment, but just that this is, now a forum where we've opened up and are starting to identify perhaps some opportunity for continued discussion and escalation to DHCS should that be appropriate. So just I'll make sure that's on their radar as well.
Great, thank you. Anyone else? Questions, comments, things that you want to lift up? We'll see.
Just one last comment. I think how we go about this is also important. We have seen a huge growth in IHSS, astronomical, especially in the San Joaquin Valley area. I mean, I'm sure it's not just the valley, but other areas. So we need to be strategic. It's not, we have already seen challenges staffing wise, as far as administrative. So we are seeing our numbers are growing at a much higher rate. So we have to be strategic how we do this onboarding of new clients that definitely we want to bring on board those that are eligible for services, but we need to be strategic. We don't want to do it in a way that we are unable to keep at where the client are experience undue additional stress because of the delays. So we need to be strategic about that implementation.
Yes, thank you. So if we don't have any more questions, comments, I'm gonna go ahead and end this great meet and greet that we had and the lively discussion, the questions that were raised during the presentation. Really appreciate that. And like Andrea mentioned early on and in the chat, we are going to capture all the questions that were either asked in the chat or live during the presentation and afterwards, and share them with Kaiser to really give formal answers to all these questions. And then we will post it on the CFPIC website. I am going to send a quick email after this meeting on a survey. If counties could please participate in that survey to continue to let us know how we can continue to support and provide guidance and assistance as you lean into CalAIM and everything that is being offered under it. Anyway, appreciate everyone being here. Have a great rest of your day.